Welcome to Taking Charge of My Cancer, episode 28. I am Derly Munoz, your host, and I have a pleasure to have a great guest today, Dr. Joseph Katzs. So Dr. Katz is a D.M.D. professor, head section of oral medicine, Department of Oral and Maxillofacial Diagnostic Science at the University of Florida. Dr. Katz has an active patient care practice, and he is deeply involved in teaching and translational research. He was trained in the Hebrew University School of Dental Medicine, where he received his D.M.D. and a residency in oral medicine, followed by a fellowship at the National Institute for Dental Research, is a part of NIH, at the Eastman Dental Institute of London. Dr. Katz is a member of the American Academy of Oral Medicine. He has authored more than 220 peer-reviewed publications and sits on the editorial boards of various scientific journals. So, Dr. Katz, thank you for being here with me and welcome to the podcast.
Thank you. I'm happy to be here.
Excellent. So you want to tell us a little bit about your mission and your business?
Yes. So hello, everybody. So I'm a professor of oral medicine, and I want to spend a couple of minutes just discussing this topic because I think that for many people, it's really not clear. I'm not an oral surgeon, but I'm not a regular dentist. So this is a specialty that is kind of interface between medicine and dentistry. So just to make it more alive, so we cover all the topics, how the medical condition, including cancer and metabolic diseases, how they affect the oral cavity, how we can actually make a diagnosis of cancer, if it's systemic cancer or head and neck cancer, or metastasis from different tumors in the oral cavity. In addition to having teeth in the oral cavity, we have other structures, such as salivary glands, mucous membrane, various tissues such as the tongue, gingiva, and all of these structures, they have their own medicine and their own diseases. So it's actually a branch within medicine that covers the oral cavity. Some people call it stomatology, but it's so we have renal. We have people who deal with renal diseases and podiatry, and liver diseases, GI diseases, and there's another specialty which is called oral medicine. So not only how general conditions or medical conditions affect the oral cavity, but also how the oral cavity affects the medical condition. And there is a lot of research and experience in how uncontrolled periodontal disease, which is disease of the gums, how it affects diabetes, for example.
Wow.
So many times we see patients that have brittle diabetes, which means even with all the medication, insulin and other medications, it's almost impossible to control the patient because there is a constant focus of infection in the oral cavity, which releases all kinds of substances, cytokines and inflammatory chemokines that will increase the burden, the inflammatory burden on the tissues, and that's why it's very difficult to control the diabetic patient. So there's definitely bi-directional relationship between diabetes and periodontal disease. And I have many other conditions that have this kind of relationship. So knowing what's happening in the oral cavity is very important. And I would just want to add something that unfortunately the medical specialties, like in medical schools, they get very little knowledge on this in this area. So we think, oh, this might be covered by our primary care physician, but in reality, they don't have much information of what's going on.
Yep, you're right. Yep.
So and I'll just jump into the thing, and I'll tell you, for example, there is something very important that we find that patients that go for bone marrow transplant because they have hematological cancer, they are actually more likely to get head and neck cancer between 5 to 10 years following the bone marrow transplant. And that's something that, the medical doctors and the hematologists are not very much aware of that. And of course, prevention is the most important option for treatment. It's better than any other treatment. So this is very important for us to be there and give the examination and the information, and also educate the medical doctors about the different conditions.
Wow, you just in 5 minutes talking, there's all these things I was not even aware of.
Right.
Thinking of you as okay, you are gonna be the one discovering the tongue cancer, or you see an ulcer on the gum, or you see something happen at the tooth level that you get concerned, and then you have biopsies, and then you refer out to the ENT for further work. I have no idea that.
Right. So I just want to mention sometimes that we see patients and we see a lesion in the soft tissue or in the bone by taking x-rays. And this lesion can be metastatic breast cancer, or it can be prostate cancer, or it can be lung cancer metastasis. So about 1 to 5% of all the different tumors have manifestation in the jaw. Wow. And that's in addition to the head and neck cancer, which is the primary cause of what we do in the oral medicine clinic. So we do a lot of consultation. Like, for example, at UF, we screen all the patients that go for bone marrow transplants to make sure that they don't have source of infection before they get the bone marrow. And we can elaborate a little bit more about that, because I think it's very, very important.
So what type of prevention will you do with those? Okay,
so typically we have a patient, let's say a patient was diagnosed with multiple myeloma.
Okay.
So now they need to get autologous bone marrow transplant, which means they get their own stem cells. And during this process, they get immunosuppression in order for the body not to reject whatever we are putting back into the body.
Okay.
And one of the main issues is that if the patient has a dormant periodontal or let's say deep caries in their mouth, which has not been really bothering them, but now with the immunosuppression, the patient, well, they have let's say they have a white blood count which is like max 500 cells per cubic millimeter. That means that this infection can now flare up, and it can cause severe damage to the patient who is immunosuppressed, to the point where their bone marrow should be deferred, or it can even cause sepsis from dental origin. So that's why all the patients that get bone marrow, whether it's their own stem cells or foreign allogeneic stem cells, they need to get clearance from us to make sure that they don't have anything that we should be taking care of before the transplant itself. In addition, we do a lot of things. Let's say we talk about patients that the multiple myeloma, and after they have the bone marrow transplant, this process is very complicated, and it takes a lot from the patient's side. So they kind of neglect their oral hygiene, and that's where they get a lot of cavities. So we have a very complex methods of telling them how to avoid this. So we talk about fluoridation, and we give them fluoride with a script, or we give them trays where they put the fluoride and then they use it for a couple of minutes every day. So and that's in addition to other things that we educate them about, keeping their saliva in good shape, and making sure that they don't get fungus infection. So those are things that we take care in the clinic for the general cancer population.
Got you. Let me ask you a question. How is the fluoride? I hear that a lot in a lot of our head and neck cancer patients, right? Before going through radiation. So they really go through you guys and then get that down. Will you explain to us like what is the process, how that helps to prevent that cavity?
Okay, so what happens is that adding fluoride to your daily regimen will make the dental tissues stronger and more resistant to all the acid and the combination of acid and the carcinogenic food that patients have, especially carbohydrates, and the process will be slow, if not completely arrested. So even if there is a very small cavity, let's say that didn't penetrate deep, the fluoride will make sure that this caries does not develop into quickly into a lesion that can then cause inflammation of the part chamber and more complication. So it's really the prevention that is important here. So fluoride for many years have been very powerful tool to call what we call arrest of caries, which means stop the progression of this process.
I got you. Okay. So it's not really any difference how a patient who is having a bone marrow transplant doing that versus a patient who is going through head and neck cancer, correct?
Yes. So there is a difference. And the difference is that we worry more about the head and neck cancer because they get direct irradiation into the salivary glands. And as a result, the salivary glands are being destroyed and it's not reversible. So for them, we make individual trays where we take impressions from their cavity and we make trays, and then they apply the fluoride inside the trays and they put it in their mouth for 10 minutes.
Okay.
For the general cancer patients that get a bone marrow, we actually prescribe a special toothpaste, which is called Prevident. Okay. And then they get the same effect, maybe a little bit less potent, but by just brushing their teeth and leaving it for 10 minutes to stick to their teeth, and then they spit whatever they have left, and then they go to sleep with this paste on their teeth.
Gotcha.
So it's a little bit different, but it's the same goal for the patient.
And for how long do they have to do that, like in the head and neck cancer patients?
For the head and neck, it's for life.
Gotcha.
And also for my BMT patients, it's also for life, because the risk for caries, it does not diminish over the years because of the damage. There are some additional things that maybe I'll discuss later that come with the bone marrow, such as chronic GVHD and other complications, but they definitely caries and periodontal disease are very, very important factors, because we don't think about this. We think it's only dental, but that's what I tell my students. The mouth is part of the rest of the body.
Yes.
So it doesn't matter, to the body systems where the inflammation is coming from. Is it coming from the skin, or is it coming from the GI tract, or is it coming from the oral cavity, which is actually part of the GI tract?
Mm-hmm. Got you. That's super interesting. So how about, you mentioned salivary glands, and that's something that does with a lot of patients' quality life with head and neck really get such a hard time with it, just because their mouth dry and sometimes, depending on what type of cancer, but many times with radiation and the surgeries, that's what's going to get involved. So is anything that you advise patients to try to help with that?
Of course. So thank you so much for the question, because it gives me an opportunity to talk a little bit more about this whole phenomena of what we call dry mouth or xerostomia. That would be the more scientific term for dry mouth. So actually, there are few conditions other than radiation that can cause dry mouth. Like I said, there is a condition which is called Sjogren's syndrome. And I don't know how many of the audience have heard about that. It's an autoimmune disease where you have dry mouth, dry eyes, and some type of autoimmune condition. But the dry mouth is very severe. It's usually the main cause for the patient to go and seek some help. Now, here's where it gets very interesting, because if they have rheumatological issues, they go to see a rheumatologist. If they have eye issues, they will go to see the ophthalmologist. And if they have dry mouth, they come and see us. And we call it orphan disease because it's very difficult to get diagnosis, but we diagnose the patient by doing, it's called minor salivary gland biopsy, or by doing some laboratory tests. And then the other condition, hepatitis C, can cause dry mouth. Okay. Inflammation of the glands can cause dry mouth. But back to your question, so actually, there is a lot that can be done for this patient, starting with controlling their the environment. So it's very important to make sure that the patient does not have open cavities and periodontal disease and so on. And then trying to get their saliva, whatever is left in the gland, which usually is not much if there was a direct effect of the radiation on the glands, we use stimulation of the glands. So sometimes simple things such as, let's say, sucking on a lemon drop that has no sugar, because the physiological action of just trying to swallow and sucking on a candy, that will make the gland, like massage the gland a little bit from the inside. Okay. So if there's a reservoir of saliva in the gland, it will secrete more. But the most important thing, you know, the NIH and the FDA have approved a couple of years ago a specific medication. There are two types of medication. One is called pilocarpine. Okay. And the brand name is called Salagen. Okay. And the other drug is called Evoxac. So those are prescription. They can be written by a primary care physician or by us, and the patient will take up to 3 tablets a day, and it will stimulate their saliva by triggering or by activation of the salivary innervation. So, but the problem with this drug is that it activates not just the saliva, but also sweat glands, because it's the exocrine system that is being activated, the cholinergic system. And then, so the patient will have more saliva, but they also will respire more. Okay. And sometimes there are some side effects that that will affect the heart. So we have to make sure that the patient does not have some kind of underlying cardiovascular disease. But most of the time it's very effective, and it helps significantly, especially the quality of life for these patients.
Okay, that's super great to know, because we hear that a lot. The other thing I tend to hear a lot is because I work really close with the radiation oncology, and we really get to see most of their patients, is osteonecrosis of the jaw.
Oh yeah.
Is anything from your standpoint that can help with that?
Okay, so osteonecrosis of the jaw, or what we call medication-related osteonecrosis of the jaw, is an entity which is very unique. I mean, I'm personally very interested in that. There are lots of research that I'm doing on this topic, including something that I hope is going to be kind of breakthrough. So the question is, why only, let's say, 10% of the patients that get the cancer drug, zoledronic acid or Zometa or alendronate, Aridia, so those patients will develop an area in the jaw where you have exposed bone which does not heal. But so the explanation is that the drug is actually inhibiting special cells that are usually resorbing bone. And patients that have, let's say they have breast cancer in the jaw, and the breast cancer will resorb the jaw, or resorb the other bone where they have the metastasis and cause fractures. So to prevent this from happening, they're giving them the drug. But this is a side effect of the drug that we can see it in about 10% of the population that get this drug, but it does not affect everybody. So there are risk factors. So what are the risk factors? So first of all, patients that have periodontal disease for some reason, they are more likely to get what we call ONJ or MRONJ, that will be the exposed bone, osteonecrosis. Oh, so you're talking, I mean, so there are two things. There is which we need to talk about the differences. So there is osteonecrosis of the jaw, which I just described. And there is another condition, which I think you may have alluded, which is called osteoradionecrosis.
That's right. That's right. You're right.
Yeah.
Yep.
So which is different. So this happens when patients get radiation into the jaw, and as a result, the bone becomes very sclerotic and almost avascular. So there's almost no blood supply. So now if the patient needs an extraction, there will be a major problem for the dentist to do the extractions, because the area that lost vascularity is not healing. So in the past, we used to do hyperbaric chambers. And but the recent studies show that there is not much value to this, and also it's very, very expensive.
Okay.
So I mean, you can spend a couple of hundreds of thousands of dollars for that, and not in all cases it will be it will actually do the job. So but the way around this is to use methods of radiation which emit less radiation. So for example, in Jacksonville, they have a machine which protonic, and this will be more localized, and they will give it more less radiation to the area, so the bone will not receive so much radiation, and the risk for osteoradionecrosis is reduced. And also to the salivary glands, the risk of damage to the salivary gland is reduced. So there's always, along the years, there have been a lot of attempt to negate those effects of radiation, but unfortunately, it's still the main mode of therapy for head and neck cancer.
Okay. Well, that has been super, super helpful. What else you want to tell us a little bit more about other, you have sometimes, how can we educate the audience out there? Like, I hear the story, right? I have an ulcer, I have something on my gum, I went to the dentist gave me antibiotic, 6 months go by, and all of a sudden this is cancer that hasn't been diagnosed from the beginning. So what can we give to our audience that they can be more proactive and just kind of push more, like, okay, let's just don't go by necessarily waiting those 6 months, but just do something more prior to just let it go too far, that in the beginning, if we discover early, could be a very specific, simple surgery, and now become this big surgery because it's already extending, right? Due to a lack of diagnosis early on.
Yes, exactly. So first of all, let's put it this way. Every patient needs to get at least annual oral cancer screening. It's a specific exam dedicated to rule out cancer. It has to be done by the dentist every year, and usually separated from the dental treatment, because the dentist needs to use all kinds of appliances, and sometimes they use different light to look at suspicion areas, and make sure that they cover all the spots. I'm going to mention a couple of those spots where there is a higher risk for cancer. Then I'll describe it a little bit. So, for example, the tongue, on the sides of the tongue, under the tongue, and then on the gums, and on the palate. Where very close to where the tonsils are. So those are areas that are more at risk to be affected by oral cancer. Now, oral cancer has two forms. It can be an ulcer where you have actually it goes deep into the tissue, and the most important thing is if somebody has an ulcer which is not healing within 2 to 3 weeks, that means that it needs to be seen by a specialist. So there's no really reason to prescribe antibiotics if there's no infection involved. But if something does not heal within 2-3 weeks, which is usually the healing time of ulcers, different ulcers in the mouth, that means that something is happening, and the sooner the better.
Okay.
So like I said, there is an ulcer, and then there is also something which we call it's exophytic, which means it's a bump. Rather than an ulcer, it's something that stays out of the oral cavity, kind of bulging out, like a lump or a bump. And again, it has been there for some time. It may be something benign, which usually it is. Not every bump is cancer, but it should be checked. Now, I also want to talk about risk factors, which I think is very, very important. So the risk factor, especially in Florida, have been traditionally smoking. And I still see patients that, smoke 2-3 packs a day, or they've been using chewing tobacco. And you can see the area where they put it, usually inside the cheek. And those areas develop almost like a burn of the tissue. And this will be the area where a cancer, oral cancer, will develop. So smoking, and then chewing tobacco, and then also we have the alcohol consumption, which if you drink alcohol, I mean, there are some new guidelines from American Heart Association. Even one glass of wine a day is not good for you. So if somebody is really abusing alcohol, that's definitely on the cancer side is very, very significant. But I actually wanted to talk about a risk factor which has gained more and more momentum over the last 10 years, I should say, and that's the HPV. And there's a whole new story about HPV.
So, would you mind to describe that to the audience?
Yes. So HPV, human papilloma virus, is actually a sexually transmitted disease that is responsible for cervical cancer. And it used to kill hundreds of thousands of women over the years until in 2006, they started to vaccinate girls pre-puberty. And since then, we see a constant decline of the cervical cancer. What's interesting is the same virus, it's called HPV-16 and HPV-18, that are causing cervical cancer, are also associated with head and neck cancer. But what's interesting is that head and neck cancer is a disease that affects more men than women. So it affects 2 to 1, 2.5 subject will be men and only 1 subject will be women. While cervical cancer affects, of course, only women. So over the years, when they started to vaccinate, they didn't think that there is an indication to vaccinate boys. So the boys are not vaccinated. Sometimes when a family goes to vaccinate the girls, the physician, if he is knowledgeable about that, he said, why don't you vaccinate the boys as well? Because the boys will be at risk of head and neck cancer. So recently, in 2020 only, the FDA has recommended that the same vaccine will be used to vaccinate males, young males at pre-puberty, let's say like 10, 12, in order to reduce the burden of head and neck cancer. Because there are almost like 2 peaks for the HPV. So one will be when young adults start dating and there is a spread of the infection. It's actually infection of the virus in the oral cavity. And there's another spike at the age of 50 where the virus migrates from the oral tissue to another area. And that's where they're going to get HPV oral cancer. So my message to the audience is actually vaccinate your children. Whether they are girls, they will get it, but also vaccinate the boys. It will protect them from anal cancer, or as well as oral cancer, and it's a very safe and very effective vaccine. So it's just a question of how much your primary care or your doctor really knows about the association between HPV and oral cancer. So according to the studies, only 25% of the medical doctors relate HPV to oral cancer, while we see that about 70% of oral pharyngeal cancers are caused by HPV as a major risk factor rather than alcohol and smoking. So it has a huge effect on the prevention of head and neck cancer. Now, I also want to emphasize this, that why prevention is so important. So about every year, there are about 30 to 50,000 new cases of head and neck cancer. Mm-hmm. The 5-year survival of these patients is still poor. It's about 50 to 60% survival after 5 years. And the main modality of the treatment is radiation. So it's a very difficult condition to treat, with a lot of morbidity for the patient. Mm-hmm. If we are able to prevent this from happening in the first place by giving the vaccine, that's a huge benefit to the whole population. And yes, it's difficult to discuss this because HPV is a sexually transmitted disease. Mm-hmm. And many dentists feel like they don't want to talk about sex and oral sex because that's the main mode of transmission. But it's something that it needs to be addressed at some point. Absolutely. Because it has a very great significance. And if you don't want to talk about that with your dentist, you can just go and look at the literature, go and see resources. NIH has published a couple of papers on that, but it's a very serious topic that needs to be addressed.
Yes, and I'm so glad you mentioned that. I have a question for you, but I have a question before that. You mentioned P16 and then P6, P18. So what's the difference between one versus the other?
So when we talk about HPV, we talk about a family of viruses. Okay. There are about 120 different species, different viruses in the family. Okay. Not all of them are related to cancer. Not cervical cancer. Actually, the majority of them are just causing like little condyloma-like lesions. So like little like bulging on the tissue, on the skin, skin tags, or something like that. But there are two strains that are notoriously known for causing cancer. One of the HPV 16, it's HPV 16, and HPV 18. And 16 is the one that is more involved in oral cancer, but actually both of them have a role in this. And it's such an important marker that these days the OBGY, when they see changes in the cervical area, they actually do a biopsy and they look for HPV. They don't do pap smear anymore. They're actually looking for the presence of HPV in the tissue. If there is a presence of HPV in the tissue, that means that the patient may have pre-cancer or even a cancer in the cervix. And the same goes in the oral cavity. Unfortunately, when we see cancer, it really doesn't matter if it's HPV related or not. We just excise it. And then, as a matter of fact, if there's a HPV, if we do a staining and it's positive for HPV, the patient actually has a better prognosis. So that means that they have a better prognosis compared to somebody that has HPV negative oral cancer. So there are differences, in the behavior of the viruses in the different tissues.
That's excellent. That's so great. That's such a great information, Dr. Katz. And then we come across a lot because we know has been a lot of success with treating HPV cancer or pharyngeal cancer, which is radiation and chemo versus surgery. So we come across a lot of these patients coming from radiation. And you're right. It's amazing how patients have no idea about this, right? And so this is already adults who we start talking about, this is a sexual transmitted type of situation, how they can really, if they have kids, and really reinforce vaccinations with kids. I remember my kids now are 25 and 27, so they're not little anymore. But I remember the pediatrician back then telling us about it. I was like, what? Like, I don't want to get my kids vaccinated. What are you talking about? They're like, 14 or something like that. That was the age they were at. And it is sad, but this is exactly the society that we live in now. And if we can be more proactive, we can really avoid a lot of trouble for them in the future. So I know
Yes.
it's been a lot of stuff with pediatrician, really try to talk to parents and make them understand, you're just going to have to, just be proactive to try to avoid this later.
There's something also very interesting. So initially it was oropharyngeal cancer, like you mentioned, that was associated with HPV. But we actually see a rise in the oral cancer per se, association with HPV. So it's increasing. While we see a reduction in the cervical cancer, we see increase in the oral cancer. And the main increase is in those that are HPV related. And I also wanted to mention this study. There's a very good study, was published in New England Journal of Medicine in 2009. It was epidemiological studies where they showed clearly that having multiple partners, sexual partners, increases the chances by 3 or 4 times, and then also being engaged in oral sex, it also increases the risk. So again, this is a topic that is kind of delicate. We don't want to go there, but this is the evidence. This is life, and people need to know about those risks. So I think that at some point we need to do more about that. This is probably my main cause for talking to you today, is maybe getting the information. Studies show that medical students, only 10% of them, when they finish medical school, they know about this, about the link with oral cancer. So, that's another reason why we don't get the vaccine. Now, there's something else. In order for the FDA to approve something, they need to have longitudinal studies, like studies that go for years. But if we are going to vaccinate a boy when he's 12 years, and we want to see if the vaccine is effective, we'll have to wait until he's the age of 50 to see if he's protected from oral cancer or not. So it's very difficult to do. But we did a study at UF, and we found that by doing cross-sectional studies, that actually if we look how many patients that get vaccinated have a history of head and neck cancer, and it's a very small portion compared to those that were not vaccinated. So there's definitely benefit to this, and all the studies are pointing into this.
Wow, this is some really great information, Dr. Katz. We can talk for hours, right? So
yes.
So many topics that we can kind of look into it. So that's really great. Is any last tip that you feel you want to bring to our audience of value?
Yes. So at UF we have a special clinic dedicated to head and neck cancer, where they've been followed up periodically and make sure that they don't have residual cancer, or they don't have complications of the cancer treatment, the radiation or the chemotherapy or the surgery. We take care of their opportunistic infection, which is a big problem, especially yeast infections and candida. Different health centers, because I think it's becoming more and more prevalent in other medical centers. But just look for those who specialize in this area.
Okay, great. And I will put all the information about how people can find you on the description of the podcast. So Dr. Katz has been really a great information. You're full of knowledge, like I say. I'm sure we're going to have to do a part 2 because I can totally get a lot more info from you that is such a great value to our patients. So I really appreciate you being here with me today.
Thank you very much.